All right, well, thank you for that very positive approach, and I think it's consistent to the point where we can start being more optimistic about MDR-TB. But there are obviously a number of problems that still face us, and our next speaker will address some of those. We need to find the patients before we can give them good treatment. And Professor Gavin Churchyard, who is the founder and CEO of the Orem Institute and professor at the University of Witwatersrand and at the London School of Tropical Medicine and Hygiene, will talk to us about the accessing MDR-TB exposed households, the Phoenix MDR-TB feasibility study. Dr. Churchyard.
Thank you very much, Bob, for inviting me to give this presentation. So MDR-TB contacts are at high risk of developing or becoming infected and developing TB disease, and in high HIV prevalent settings of dying. We know from a large systematic review that household contacts have a 4 to 8% chance of developing active disease, and of those that do, the majority actually have MDR-TB. The World Health Organization does not recommend treatment for presumed MDR-TB infection and recommends that there is strict clinical monitoring and follow-up for up to 2 years, but also calls for more research for treatment of presumed MDR-TB in high-risk household contexts, notably children less than 5, HIV-infected individuals, and those that have evidence of infection. To address this unmet need, we will be conducting the Phoenix trial, which is trying to evaluate the use of delamanid versus isoniazid in treating household contacts exposed to MDR, pre-XDR, and XDR-TB cases. So in preparation for the main trial, we have conducted a feasibility study which aims to describe the feasibility of identifying, recruiting, and characterizing adult MDR-TB cases of index cases and their adult and child contacts, and to describe the prevalence of latent TB infection, TB disease, and HIV infection among adults and child contacts. This is a cross-sectional study with a 1-year follow-up. The aim was to enroll at least 300 index cases of MDR-TB and all eligible household contacts. The index TB case is defined as a person 18 years and older with evidence of pulmonary MDR-TB. And the household contact is a person who lives in the same dwelling unit and shares the same housekeeping facilities as the index case, and who reports exposure within 6 months to the index case starting MDR-TB treatment. We evaluated at a site level the index case and household contacts. This study was done in 16 sites in 10 countries, with South Africa having a large proportion of the sites. We managed to identify 410 index cases. We screened 97% of them, and we managed to enroll 78%. And the reasons for those that weren't enrolled are largely unknown or for other reasons. We enumerated the household contacts, and we enumerated 1,317 contacts and managed to enroll 77%, that is 1,018. And of those that weren't enrolled, it was due to individuals saying they did not want to participate in research or being too busy. The index cases were on average 36 years of age, and the household contacts were a decade younger. In the index cases, 60% were male, and in the household contacts, approximately 60% were female. South Africa accounted for the largest number of household contacts, followed by Peru and India. We had 308 index cases that we identified, and they were identified through the community clinics, general hospitals, by the clinical research sites themselves, or referral to the clinical research sites or other sites. Documentation of the drug susceptibility testing was done from local labs at the time of enrollment into the study, and all 308 index cases had evidence of rifampicin resistance, but only 75% had documented evidence of isoniazid resistance. So even though they were declared programmatically to be MDR-TB, it was only confirmed in 3/4 of them. The characteristics of the MDR-TB cases: over a third were HIV infected, only half had prior evidence of TB treatment, 65% had cavitatory disease, and 70% were smear positive, and the average duration of treatment by the time we enrolled them was 6 weeks. In terms of the age distribution of the household contacts, 10% were less than 5 years of age, a quarter were between the ages of 5 and 18, and half were between the ages of 18 and 50. The enrollment of children within these sites, however, was very variable, ranging from 2 to 50%. So there was a major problem with enrolling children within these sites. HIV testing, 78% of the contacts had an unknown HIV status at study entry. 71% of the household contacts agreed to HIV testing, and we identified 5% new HIV infections. There was variable uptake of HIV testing across sites, with 9 sites reporting greater than 80% uptake, and 4 sites with less than 50% uptake of HIV testing, with the lower uptake in the age group of between 2 and 17 years. And the reasons for not taking up HIV testing included parental guardian not available to consent, or the parent or guardian refused HIV testing. And that in some sites the institutional review boards had not approved HIV testing in children, and in some instances the parents of the child was HIV negative, and because of the perception that these children would not be HIV positive, they refused testing in those children. In terms of the prevalence of latent TB infection, we did both tuberculin skin testing and the quantiferin gold in tube assay. Only a third of household contacts did not receive a tuberculin skin test due to the global stockout of tuberculin, but of those that were tested, 56% were tuberculin skin test positive. Only 3% of household contacts did not have a quantiferin gold test, and of those that were tested, 65% had a positive quantiferin gold. So when we combine these results, 70% of household contacts had evidence of TB infection by being either TST or IGRA positive. The prevalence of TST and IGRA varied markedly by country, but looking at the IGRA data because it's more complete, the highest prevalence of TB infection was in South Africa, India, and in Brazil. The yield of contact tracing was high. About a quarter of household contacts had symptoms or signs suggestive of TB. We managed to get a chest X-ray on 96% of household contacts, and 17% had an abnormal chest X-ray. We diagnosed prevalent TB in 13% of the household contacts, of which 3% had bacteriologically confirmed TB. This yield also varied markedly by site. So of all the household contacts in the 16 sites, 66% of household contacts would be eligible for TB preventive therapy, with 10% being less than 5 years of age, 9% being HIV infected, and 81% of those older than 5 years having evidence of TB infection. There were a median of 2 household contacts per index case. We also assessed willingness to participate amongst the household contacts, again showing variation by site, but overall 79% of household contacts indicated willingness to participate in a future preventive therapy trial. We also evaluated the resource utilization for doing this contact investigation. And so of the 16 sites, made 512 attempts to evaluate the 308 household contacts, and up to 5 attempts were made per household. The median household size was 4 people plus the index case, with a range from 1 to 21 persons. And the median time spent by site was that there was the staff per attempt was 4 hours, with a range from 1 to 24 hours. With respect to infection control, N95 respirators were worn by study staff in 15 of the 16 sites. All sites gave index cases surgical masks to wear, and sputum was collected in a separate area within the clinic at all sites. In terms of infection control, when transporting index cases and contacts, half the sites had access to a vehicle that had a partition separating the driver from the patients. N95 respirators were worn by the drivers at 82% of the sites, and surgical masks were worn by participants at all sites, and the windows were kept open when transporting patients at all our sites. Some of the challenges we've had engaging with households of MDR-TB cases was, as I've mentioned, access to tuberculin, the uptake of HIV testing, and the recruitment of children. But also, there was problems with having sufficient staffing, the travel and logistics required to getting to the households multiple times, and the safety of the outreach teams. They were often going into areas where there was quite marked violence, and so most teams, there were at least 2 people conducting the household visits for safety reasons. Also, dealing with the occupational exposure and infection control was challenging, certainly wearing these personal respirators when going into some households where it was hot, the transporting of household contacts to the site, and the need for separate sputum collection at the site. And then there was also an issue around stigma with regard to teams coming to households and potentially stigmatizing the households. But we found that by doing community engagement, that seemed to improve the acceptance at the community level, and after that there was appreciation of us visiting the households. So in conclusion, enrolling MDR-TB index cases and household contacts is feasible. We do need strategies to improve HIV testing of household contacts, and we need contact investigations of children to be strengthened, and household contact investigations provides a high yield but are labor intensive and require multiple resources. And there is a high willingness to participate in the trial of preventative therapy. And the Phoenix trial will be commencing in the first quarter of next year. So watch this space. Thanks, Bob. Oh, sorry. Just to mention the large team that are conducting the Phoenix trial, both the protocol team and the site investigators and study teams. Thank you.
Yes, I can see that a large team was required, so we'll give a hand to them all. Any specific questions, clarifications for Dr. Churchyard's talk? Dr. Castro.
Gavin, thank you, and congratulations. Are you also assessing the risk to the health workers who are going out to do the home visits to identify the contacts? You described what they're doing for infection control, but I'd be curious to know how well protected are they?
Yeah, so what we have is at each site we are ensuring that they've got an active infection control policy which requires the screening of the healthcare workers that are doing all of this work. But what we haven't done is sort of enrolling them in a cohort to track whether they're protected or not, and that's something we can consider.
If there's no other questions, I have one. Great. No, thank you for this, Gavin. I think it highlights a lot of things about contact tracing in terms of the resources needed to do it well. And that's a classic excuse for not doing contact tracing, isn't it? That the programs just don't have resources. But your results really highlight a lot of strengths that you can get HIV testing done well. You had 2 contacts per index case, and then the yield from this was phenomenal.
Yeah.
I mean, 11%, you almost never see that high of a yield in case finding strategies. So I think it's a really strong evidence that we need to be pursuing contact tracing more aggressively. Just 2 comments, questions. I think children are vulnerable, and as you showed, they're difficult to get in to the clinics to get tested, but also adolescents. I think adolescents are often kind of invisible because they might be going to many different households, they might be staying with an aunt, and perhaps you could comment on how we could highlight that weakness. The other is a question on, do you think decentralization helped in your contact tracing program? Because I saw 50% of your patients were diagnosed at a decentralized level.
Yes.
And did that benefit the contact
Oh,
tracing?
yes, yeah. So we gave the sites the option. They could do it as they wished, whatever worked best for them. But certainly that decentralization, I think, is critical. Because certainly the initial contact and the recruitment often happens in the household. Then once that has happened, the contacts are more willing to come to a centralized facility. But unless you go to them, you make it easy for them to actually get into the system, you're going to lose a lot of people. So.
Great. And what is, if I may ask, the preventative therapy that will be in the trial?
Delaminate.
Ah,
So
excellent.
it's delaminate by itself for 6 months versus INH for 6 months. So it's
Great.
an active control arm.
Great. That's exciting. We'll look forward to it.
Thank you.
Thanks.
Thank you, Gavin. Our next, from Johns Hopkins University, where she's Assistant Professor of Infectious Diseases and Medicine and a member of the Center for TB Research. And she is going to talk to us about elimination of MDR-TB. What will it cost?
Yes. And I should begin with the disclosure that I'm not an economist, rather I'm an infectious disease clinician and a mathematical modeler of disease dynamics. So I'm going to come at this question from that perspective, saying first of all, what do we know about where MDR epidemics are headed and what's driving them? What are the implications of that for thinking about what it will take to get to elimination? And then offering a few just sort of example perspectives on costs and what it's sort of reasonable and possible for us to pay to get there. I like this figure from last year's global report in terms of thinking about where MDR epidemics are sort of going relative to TB epidemics overall. This is just data from the places where we actually do have longitudinal data on incidence of drug-resistant TB, shown as the red lines compared to TB overall in those settings in the blue lines. And I think the lesson here is that in each of these places, the MDR trend is either growing more quickly or declining more slowly than TB overall, which is what we sort of expect to see from just the dynamics of the epidemics also, that over time we should be expecting that as we pursue overall TB elimination, MDR-TB is going to be a growing proportion of TB cases. And in terms of what we know about what's driving MDR-TB epidemics, I think we have to know what's driving it in order to understand what interventions are going to, alone or in combination, be able to get us to elimination. So first of all, there's acquisition of drug resistance, and here I'm talking about acquisition of rifampin and isoniazid resistance. We know that around 1% of drug-susceptible TB treatment courses result in acquired MDR-TB. And that's even with fairly good treatment programs, but it means that as we get closer to elimination of drug-susceptible TB, that's going to reduce the inflow of MDR cases. But we also know that we're already to the point where the majority of new MDR-TB cases are transmitted rather than acquired during that person's previous treatment. That's borne out in molecular epidemiology studies and modeling analyses, and just looking at the sheer number of case notifications that are estimated to actually have RIF-resistant TB, whether it's detected or not. The cases among new notifications outnumber those among retreatment notifications, and the former are necessarily transmitted rather than acquired cases. We also know we're underdiagnosing RIF-resistant TB, and that when we don't get cases diagnosed and treated promptly, that prolongs transmission and is contributing to MDR epidemics. We also know that when we do treat, it's our treatment historically and up until now has not been very effective, which prolongs transmission, and as we saw in the last presentation, leads to second-line resistance. And we also, as the Phoenix feasibility results were illustrating, know that there's a lot of recent spread and a high risk among known MDR contacts, including children, and that should affect how we think about what interventions it's going to take in order to get us to MDR-TB elimination. And I think this suggests a multifaceted approach. Drug-susceptible TB control, moving toward elimination will, as I said, reduce that inflow, but we also need to interrupt transmission. We need to do a better job of detecting cases early before they have as much time to transmit and result in secondary cases, and things like expert scale-up and active case finding may help with that. We also need to do a better job of treating, for instance, through using drug susceptibility testing and optimizing regimens and monitoring patients to make sure that they're responding. Some of these things that we're talking about, plus development of better, more effective regimens. I think there's also a role for contact tracing, preventive therapy with drugs that are active against MDR-TB, maybe also biomarkers to detect incipient TB and identify who we need to be treating in this way. This is a modeling analysis by Chris Dye and others from a few years ago, looking at what it's going to take to get to drug-susceptible TB elimination, and showing that treating active cases isn't enough, that the treatment of latent TB is also necessary. And while the pool of latent MDR cases is relatively somewhat smaller, I think the same lessons apply here, plus probably more in terms of the multiple different approaches that are necessary in order to eliminate MDR-TB. These are just as an example. This is results from a modeling analysis that I did earlier this year, looking at potential impact of the 9-month MDR regimen in terms of what's the impact. This is sort of modeling in Southeast Asia, assuming that sort of observational results for efficacy are borne out, and assuming that the 9-month regimen, being cheaper and shorter, allows those resources to be reallocated to treat twice as many patients, sort of looking at what impact could this have. And the result published in the paper is that this could achieve a 25% or so reduction in MDR-TB incidence over 10 years. But I think the other thing that's worth noticing is that, and this is true in other analyses also looking at better diagnosis and more effective treatment of MDR-TB, is that on the one hand it can have a significant impact because there's a lot of improvement to be made in our detection and treatment of drug-resistant TB. But on the other hand, that effect plateaus, and that's something we see consistently. And eventually more other types of interventions are also needed in order to get to that elimination target. And it's hard to project exactly what combinations will be required and in what combination. And I think there's a role for sort of additional data collection together with modeling to try to identify how much of different interventions it's likely to take. It's also an evolving question as our technology improves. But more importantly, I think to identify what are going to be the most efficient sort of packages, combinations of interventions in order to get us toward elimination at the lowest cost possible. But in terms of thinking a little bit about the cost of some of these interventions, why aren't we doing more now with the tools that we have? And I think to a large extent cost is prohibitive, or at least is perceived as prohibitive when it comes to MDR-TB control. Here are example costs for a few of the interventions that we're talking about. And with the largest being just the cost of treatment, averaging around $3,000 in low-income countries, according to budget data reported to WHO each year. And as a result, the proportion of TB program budgets that are devoted to MDR-TB control in high-burden countries is much larger than the slice, representing the proportion of notified cases that are drug-resistant. And as a result, we're underutilizing these tools that we have, with only about a quarter of new TB diagnoses getting rifampin drug susceptibility testing, and only about a quarter of incident MDR-TB cases ever getting notified. And of those that do get diagnosed and started an MDR-TB treatment, only around 40% getting second-line drug susceptibility testing. And there's not even good data on contact investigations at this point, but based on uptake of sort of preventive therapy for child contacts of drug-susceptible TB, for instance, where it's recommended, where uptake is low. I think, presumably at this point, there's not much contact investigation happening in high-burden settings for MDR-TB either. I want to, just as an example of ways to think about how much can we and should we be spending on MDR-TB interventions, just want to focus for a moment on an analysis looking at how much can we afford to pay or should we pay for improved treatment regimens for treating rifampin-resistant TB, and just illustrate a couple of different perspectives that can give very different results. The first of these being thinking about just within the program budget of a national TB program, and thinking about sort of within our upcoming budget year, what would be a budget neutral price to pay for an improved regimen. And this is, I'm not showing methods here. This is using fairly crude budget data, but estimating what proportion of management costs could be prevented through, say, a RIF-resistant regimen that has efficacy sort of approaching that of HRZE and 6 months duration, and more tolerable an oral regimen, sort of estimating how much that could reduce management costs, and saying if that proportion of the budget were instead spent on increased drug spending for those same patients, how much could we afford to pay, and looking at across a spectrum of countries with different sort of levels of wealth and different levels of current spending on MDR-TB. You get, of course, a range of prices in the dark blue in terms of what would be the budget neutral cost for such a novel regimen sort of in the current year. So not accounting for downstream effects on transmission, but just saying what could we pay now. And it's ranging from like $3,000 in India, for example, $2,000 in DRC, where current spending is unreported spending is even lower, up to more than $10,000 per treatment course that could be afforded just by diverting existing management costs in more middle-income countries, such as South Africa and Russia. But then there's another perspective that we can take in terms of how much should we as a sort of global community be willing to pay for an intervention that's going to help make significant strides in MDR-TB control. And here, in addition to looking at our current year budget and saying that that changes to this distribution where, because we're spending less on management, we can spend more on drugs, we also say, well, over time, a better regimen is going to have an impact on MDR-TB incidence, and so those management costs are going to shrink further as we have fewer patients needing treatment, which could be reallocated, say, toward drugs, if that's what we're thinking about now. But then also that better regimen is going to produce reductions in prevalence and therefore in morbidity, and reductions in mortality. And those have we can place economic value on those improved health outcomes. And so in this cost effectiveness analysis, taking a model similar to the one I was talking about before and looking at what kind of impact can such a regimen achieve. And again, this isn't the regimen that we're talking about, but it's illustration of the kind of model projections, translating that into years of productive life, into averted, prevented deaths, and placing value on those. We then get estimates of the cost effectiveness of such a regimen. And this is saying if that regimen cost $10,000 per treatment course, what would be the incremental cost effectiveness ratio of such a regimen per DALY, sort of per disability adjusted life year that you prevent with the regimen. And in DRC and in India, this now $10,000 regimen is costing well under the GDP per capita per DALY averted. So saying on the one extreme, there's the fairly small increase in the cost of an intervention, or in the cost of an intervention that could be done within current budgets. On the other extreme, if we're thinking about the actual value of interventions we can afford to pay much, where we can justify paying much more in terms of what can we actually afford and what can markets support, or what is the sort of global community willing to fund, probably falls somewhere in between. For each of these interventions, I think it's hard to know how much each of them will cost, but we're looking at something along those lines. I'm going to skip over this. So say that on the one hand, we need to reduce costs of diagnosis and treatment, but we also need to invest more now, preventing that transmission, and could ultimately have a large health impact, also in some cases prevent us from having to spend more down the road. I'm not going to try to name a price for what it's going to cost to eliminate MDR-TB. I think it's partly there are data gaps. It'd be hard to put a price on drug-susceptible TB elimination, even in absence of drug resistance. It depends in part on evolving technologies. Do we have good drugs to provide preventive therapy for these contacts? How much are our diagnostics and treatment regimens going to improve, and what are they each individually going to cost? But I think it's clear that elimination requires a multi-pronged strategy. We need to work to make each of these interventions more affordable, and we need to understand our local epidemics in order to design the most efficient packages of interventions in order to do this at the lowest cost possible. Some of these interventions that are highly cost effective will still strain current budgets and capacity. So if this is something that we are going to do, it's going to take global commitment and some investment, but ultimately I think very justifiable to spend that. Here are some people who worked on a few of these analyses, some of the cost effectiveness work that was done with WHO's task force on new drugs, and some collaborators at Hopkins that worked on some of the transmission modeling. And thank you.
Dr. Kendall. Any questions for Dr. Kendall? I have one question, or maybe a comment. I'm also not an economist, but it does seem to me that your data show that the size of the global MDR-TB epidemic is increasing, and that means that the longer we wait to make investments, the more it's going to cost us, and in essence, the less cost-effective it will be. Is that true?
I think there's some uncertainty in whether it's sort of roughly flat or increasing, but I think the proportion of the proportion of cases that are drug resistant is increasing. There's not a significant decline in drug-resistant TB at this point, certainly, and the amount of second-line drug resistance that's making cases harder to treat. And the fact that we're spending a lot to treat current cases, but that each one is maybe generating, on average, one additional case downstream, means that it would be, in some sense, if you have a long enough perspective, cost-saving to act sooner rather than later. Great. Yeah.
Thank you very much.
All right, Isaac Chikwana. So he's an MD, MPH from University of Zimbabwe. He's been with Médecins Sans Frontières since 2009, and currently he's the HIV/TB advisor for MSF's Access campaign. He'll be speaking to us today about the role of policy based on the out-of-step report. Thanks.
Thank you very much. I'll start by declaring no conflict of interest. Now that I'll shift the discussions a little bit away from the clinical side of things to look at the public health impact and look at the policies. I'll present some results from our out-of-step report. You'll see this on your chairs. Please feel free to pick one copy. But before we go there, just a reality check of why we are talking about all these things. So this is where we are on the TB burden. Some will argue that the global population is increasing, so we have more incident cases. We can accept that, but you will see that we have stagnated on the case detection at 60% for the past 10 years or so. For MDR-TB, there's a huge gap between the incident cases and the detected cases. Out of those detected, there seems to be there's about 97% who are started on treatment, which is quite good, but let's not forget that we're missing 75% of these people. So the out-of-step report is a look at is a comparison of the WHO policies on TB control, and we're comparing with what the national TB programs have in their guidelines and how they're implementing. This is the third time we're doing this with it's MSF, it's a collaborative research between MSF and Stop TB Partnership, and we've been doing this since 2014, so this latest version is third version, and it's an analysis of these policies in 29 countries. Actually, we started with 30, but one of the countries refused to be named in the report, so we did an analysis of only 29. And the countries were chosen according to 3 criteria: if they're on the high burden MDR, TB, or HIV lists, if there was a presence of MSF or Stop TB in the country, and if they had been assessed in the previous out-of-step reports so that we could compare. So our methodology, I must confess, will probably not withstand any severe academic rigor, because we allowed a lot of flexibilities. What we wanted was to reflect the actual state on the, on the ground, not to prove anything. So we allowed countries to, whenever we felt that they could have misinterpreted the questions, we went back and we discussed, and sometimes the questions changed, the answers changed as we did the analysis. So we looked at 5 key policy areas from the WHO: prevention, diagnostics, models of care, treatment, and drug regulation. And the analysis was just doing the comparison between the policies on the ground and the latest WHO guidelines in each of those areas. And the results were presented in the form of a dashboard with some narrative. So the red dot indicates that the policy does not exist, the WHO policy does not exist in the national guidelines. The green dot means it exists. The light green with the X means it's being implemented, but not widely. And the green dot with the question mark means it's being implemented, but it's not very clear how much of the implementation. The definition of, this was a little bit difficult to do the analysis, because our definition of wide implementation was really wide to interpretation, so it depended on who was responding. So this is just an idea of the guidelines we looked at. For the past 5 years, the WHO has released at least 17 guidelines or policy updates. So we looked at the latest guidelines. The limitations of the study. We tried to ask for documentary proof from the national TB programs of their guidelines, and this wasn't always easy, because while you could have a guideline that was dated 2014, but some sections of the guideline were updated, and some sections, and the updates did not necessarily mean that it was actually written in the guideline. It could have been a ministerial order, it could have been minutes from a TB working group meeting, so it wasn't always easy to find documentary proof of this in the guidelines. And some of the documents were, especially from the former Soviet countries, were in Russian, and none of the researchers were confident in the language. So we had to use Professor Google, and sometimes the answers were not necessarily corresponding to the reality. And there were also time limitations to the cross-checking of the responses, as we had to constantly go back to the responders and ask for clarifications. Implementation was not easy to quantify, as I've already alluded to. And sometimes there was implementation, but not in the guidelines, and sometimes there were guidelines, but not implementation. And some countries thought it was naming and shaming, so they either refused to be included in the analysis completely, or they refused to validate, because at the end we had to ask all the NTPs to validate if this was the true reflection on the ground before we could go to print. So just keep this in mind as I present the results. So on the left, we have the Venn diagram from WHO of the high burden countries on TB and HIV and MDR-TB. Out of those, we picked some key countries. In yellow, we have the countries that contribute the highest, 6 countries that contribute 60% of the TB burden. In red, we have the 10 countries with 77% of the missed cases. And in green, we have the 5 countries that contribute to the MDR treatment gap. So on the diagnostics, 52% of the countries have expect for all. This is the latest WHO guideline on TB diagnostics, but only 7 have actually implemented. But the good news is that this is double the number if you compare with the 2015 out-of-step survey. But the interesting thing is that 5 of the countries with the highest number of missed cases have not included expert for all as the first-line diagnostic tool. 97% recommend expert for high-risk group. So this is the earlier version of the WHO guidelines, and a lot of the countries have this at least in their guidelines. But only 54% implement it widely. First-line DST is available in more than in about 90% of the countries, and second-line DST is available, but not necessarily in the country. Sometimes they have to outsource to other countries. On the treatment and drug regulations, shorter treatment regimens are available in less than 50% of the country. The essential medical medicines list of, with the full set of the WHO TB drugs are only available in 50% of the countries. One country actually did not have an EML at all. And only 28% of the EMLs have the new TB drugs in their guidelines, in the EML. The national TB guidelines that include bedaquiline, there's 75%, and those with delaminate, only 62%. And countries that participate in the WHO collaborative registration procedure, there's only 41% of the countries surveyed. But the good news is that quite a significant number of the countries have accelerated mechanisms to get new drugs into the country, and they also have alternative mechanisms other than registration to get the good, the unregistered drugs into the country. So it is possible to get newer and better tools into the country without while you're waiting for the full registration procedures. So several reasons were given for this discrepancy between the WHO regulations, WHO policies, and what was happening on the ground. And the 2 at the top, I think, are the most interesting. A lot of the countries said the WHO guidelines were coming in thick and fast, and they could not cope. One NTP manager actually said, I know this is going to change soon, so I'll just wait for the next version before we update our guidelines. And the question here is it avoidable? Because the drug-resistant TB landscape is changing so fast. New tools are coming up, new drugs are coming up without enough evidence. So the WHO guidelines are interim and they're being updated with time. We did a comparison with HIV. It was the same with HIV. For HIV, actually, in 5 years, there were 32 guideline updates. High costs was always given as a reason, and also technical challenges with implementation, for example, for gene expert. But for the new drugs, one thing that always came up was the health systems had no capacity to deal with the requirements of implementing these or rolling out these new tools. And obviously, there was a lack of political will and commitment. Only a few countries can actually be singled out as having shown political commitment, and I will not mention names. So, conclusion. I crossed out the MDR there, although my X moved. Just to be a little bit provocative, can we actually eliminate MDR-TB without eliminating TB? And can we actually eliminate TB? Because personally, I don't believe we can at the moment with the tools that we have. We don't have all the tools that are required. While it's very easy for us to sit here and probably point fingers at the national TB programs and the governments when they raise these concerns about the barriers they have in implementing the WHO policies, if these are not addressed, we can update the guidelines and continue. I can come back with the out of step 2020 and we'll be saying the same things. If these issues are not addressed, then we will never actually achieve the WHO targets, or not the WHO targets, the global targets to eliminate TB. But at the same time, we need to maximize on the tools that we already have. They are not the best, but we have something that we need to implement. And if we don't implement, waiting for some final guidance, we'll always be behind. And probably we need bolder and stronger guidance from the WHO. I have experience from the field where you go to the WHO country office and they tell you we're WHO, we just advise us. But the interesting thing is that a lot of the countries actually listen to WHO. So if WHO says this, then most countries will probably follow. Although the implementation might be slow, but they do listen to WHO. And in the background, there is need for more political will, there's need for more investment into development of better tools that will actually make us achieve our goals. In our acknowledgements, I would like to thank the Stop TB Partnership, the MSF Access Campaign, and the National TB programs and the MSF teams that participated in the research. The full out-of-step report can be found online or hard copies. You can contact the Access Campaign or Stop TB Partnership if you want the full report. Thank you very much, but I'll leave you with this slide of the latest resistance form that we have in TB. Thank you.
Questions? Please, Dr. Castro.
Isaac, thank you. Poignant demonstration of the need to bridge the policy to practice gap. I was curious because you showed that over 80% of countries that you surveyed reported having access to both first and second line drug susceptibility testing. And my curiosity stems from my own observation that too many countries are still relying on aggregate proportion method in solid media, which is irrelevant to patient care. So even when you have it, it's not being used to optimize treatment regimens. So if you could dig deeper into that, I would very much appreciate it, because I think that would be another demonstration of a gap, even when it appears rosier at first glance. That I think your numbers were 89% had widely available DST. But if it's aggregate proportion, I don't want it.
Thank you very much. I think that's a topic for discussion on its own, on whether we should be doing science-based prescription for TB treatment, or there's this fear in the global TB community. It's not now, it's been happening for the past 50 years or 100 years. TB has struck fear in people that the moment you do RNR, you put somebody on full regimen. So this is a discussion there that could take, it's a discussion on its own, yeah, but thank you very much for that.
Isaac, I think you've done a really nice job of sort of outlining what you have to do past the stage of just making a recommendation. You really need to identify trackable indices and track them, and then hold countries accountable for progress. And the WHO has put out a very optimistic set of recommendations, but I haven't seen in it any real concrete issues of what the milestones are and what the monitoring plan is and who's going to hold the feet to the fire. Is someone doing this, or where do we stand with this? Because we won't make any progress if we don't do that. or we won't know if we've made any progress.
I see Vivian is smiling because this is something that we've actually been working on with a group of stakeholders in TB to have some accountability, not just from the WHO, but also from the national TB programs, that we need. It's nice to have this 90 eliminate by 2025, but we need more tangible goals that, every year, maybe not, but every couple of years, somebody stands and says, this is our targets, this is where we are, these are the challenges, and this is what we need. So we are actually working on a document to be presented at the Moscow ministerial meeting and hopefully to be taken further to the UN high-level meeting in New York next year to have governments be accountable for TB control.
Amen, right? And I think, that was my main point as well, was that I think as a community we have forgotten to set these types of targets. We got bedaquiline, we got delaminid, and I think a lot of us thought these drugs are so great that we won't need to monitor uptake. They will be taken up and they'll be distributed like candy. Everyone will use them. And then here we are 5 years later. Bedaquiline was approved 5 years ago in December, and look at how low our uptake is. And we fell short in setting targets. And I think going forward, say with the BPAL regimen or pertominid or delaminid for children, we have got to be proactive in setting the targets now. And it's always a delicate balance. This isn't a punitive thing to outline countries to say where there are. It's simply identifying areas that can be used to target technical assistance. But I won't, I can go on and on about this, so I won't. But I think another interesting thing for out of step to consider looking at is the implementation of LPA. Oftentimes we ask countries, are you using second line LPA? And they say yes. But what does that really mean on the ground? Does that mean they have to send them to a supranational reference lab, or is it actually functioning at the national reference lab? Because I think second-line LPA is really kind of at the crux of our treatment decisions right now. Another thing is, and this is an access campaign idea, is what is the time to patient? And the time to patient for something includes even the time before it gets into WHO recommendations. So I think a lot of us have seen, say, PK data on delaminid down to the age of 3 in children. How long is it going to take for that to get into the WHO recommendations? So it's a step before what we're looking at already. So perhaps this spectrum of the time to patient for drugs, for regimens, say we have BPAL and it gets FDA approval within a year and a half, we start the time ticking there as to when the patients that need BPAL are going to get it. But just some comments there. I don't think I actually had a question for you, Isaac, but would you like to make any last comments there?
Thank you. Just maybe on in relation to LPA, I think one of the weaknesses of the out of step is that it's a very quantitative report. It just says who's doing what. But since we published this report, we've actually picked two, from our findings, we picked 2 topics, like the implementation of GeneXpert and the uptake of the new drugs, to really try to go back to the countries and dig deeper into the why things were not being implemented. And I think this will strengthen the advocacy so that we address those challenges, not just look at who's not doing what. So the report on the GeneXpert should be coming out at the end of the year, and hopefully shortly after that on why there's a slow uptake of the new drugs.
Thank you.
So we went through quite a bit of material here. We did say we would hold some time for questions at the end. We don't have much, but we do have time if there's 1 or 2 burning questions on any of the earlier presentations. Now is your chance to come to the microphone.
So when you have such a high proportion, is the strategy a public health one of just treat? It's unlike, in the US where it's going to be much lower, then you do need a test and treat strategy. And so it's something that we are grappling with. Certainly for the kids under 5, I feel very strongly there should be no test. It should just be treat. And in fact, in terms of the randomized evidence for treating infection in household context, really for only drug-susceptible TB, and they're old trials, they go back to the 1960s, there's 3 or 4 of them. But what they show is that treating all contacts has benefit. So, I think it's a debate we need to have, because at this point in time, there's no clear guidance on what we should do.
Other questions? If I may just take 2 more minutes of your time. I had a question for Christoph in his first presentation. So I really liked your point that we probably need some outcome definitions and some targets for following patients after the completion of treatment for potential relapse. But I wanted to ask you the question of, can you offer your opinion to us on the role of whole genome sequencing in the future of DRTB? I've been asking a lot of people that because I'm not quite sure what to make of it yet. You mentioned that it's about 50 euros right now. That's about $60 US. That's about 800 South African rand. How do we get the cost benefit balance?
So I'm living in a fairy tale world. We spend at times about 500 euros per day for drugs for our patients. So 50 euros for diagnostics in a disease that needs 20 months of treatment is nothing. I see the world moving in this direction, that the bottleneck will be overcome, hopefully shortly, that it will be able to reliably, in those who have sputum smear positive pulmonary tuberculosis, to extract and isolate and enrich Mycobacterium tuberculosis DNA directly from sputum, and to do this in an automated way. Now, those of you who read the New England Journal 2 weeks ago, you saw that there was a new cartridge of the Cephite Gene Expert proposed, like as a second step, with isoniazid injectable and fluoroquinolone drug susceptibility testing by molecular methods. If you think a step further, and there would be a method where the whole genome of the bacterium in the same situation could automatically be typed and sequenced, and then this running on a car battery or something that would work in peripheral South Africa or somewhere else. The sequence will be uploaded and via satellite goes to a reference laboratory. The reference laboratory has the sequence and compares, or has the sequence of comparison H37RV strain, compares it to the sequence that you upload, and they run an algorithm through it and show that there is the 350 CAT-G mutation that is a high-level isoniazid resistance. There's the 531 RPOB mutation that is the high-level rifampicin resistance. There's the 94G JAR-A mutation that is causing a high-level fluoroquinolone resistance. And so they identify certain resistances, and addressing a algorithm like the one proposed by Bob and colleagues, a type of algorithm is then matched with the result coming from the sequence, which is all going to be automatically. And then going back to the provider somewhere in the bush where the machine stands and saying, okay, for your patient, the optimal treatment regimen, first choice would be this and this. If your patient has renal insufficiency or has hepatic insufficiency or getting antiretrovirals that are being metabolized by CYP 340, no, that was wrong, 450. Then the alternative regimen would be this and that, so they give you a choice of regimens, and basically for all this would be technically possible today, but we don't have the automated Illumina or whatever machine yet that does that what the Gene Expert does currently. But this is how I will see it in a few years from now, and we will not talk about proportional methods anymore in the field, because all of this will be substituted by molecular drug susceptibility testing and will go to reference libraries and will go back to the provider. Thank you.
Yeah, great point. I know we hate HIV analogies, but wouldn't it be nice to have a Stanford database for TB, like we have for HIV?
Absolutely, and there are several groups who are currently working on this. There's the RESEC group, which is funded by FIND and CPATH and the WHO. There's just a manuscript on standardized documentation of the genotypic to phenotypic drug susceptibility testing was yesterday accepted at the European Respiratory Journal, so it will be coming out shortly. We're just 10 years behind the HIV guys. So all the HIV physicians know what the mutation is that causes efavirenz resistance. And presently, perhaps you, because you're here in the session and you're extra motivated, you know what causes high-level isoniazid resistance. But 95% of our colleagues out in the field today don't know this. But in 5 years, I bet you they will know, the majority will know what the key mutations are, and they will select the drugs according to this.
Brilliant. No, I think that's it's a nice goal to work towards. And then if you could throw in what doses we should be using, that would be great, because I think we're like chronically underdosing so many of our medicines. So, you know, what does intermediate resistance give you what dose? And sorry, I know we're well over time. So.
Yeah, let me say, I think that our speakers have made some really terrific presentations. I'd like to thank all of them. I'd certainly like to thank all of you for sticking out with us for the end of the last session. I think the prospects for elimination of multi-drug resistant TB are better than they've ever been, and I hope they will continue to improve. Thank you.